I'm not worried about that.
Good evening, everyone. I'd like to call to order this hearing of the Health, Finance, and Policy Committee. We're in a different room than we're used to, but, and I know it's not as much fun to have hearings in the evening, but thank you, everyone, for being here. We are coming up on the first deadline, so we do want to get as much work done here as we can today. So the first order of business is approval of the minutes of March 2nd. Is there a motion to approve the minutes? Representative Perryman.
I've read the minutes, and I so move the minutes for approval.
Thank you very much. Any discussion to the minutes?
And thank you, Chair.
Seeing none, all in favor of approval of the minutes of March 2nd, please say aye. Aye. Any opposed? The motion prevails. The minutes are approved. Okay, the first bill on our agenda this evening is House File 645. Chair Lee is here with House File 645, and since he's not on the committee, I will move that House File 645 be laid over for possible inclusion in an omnibus. And just so members understand, this actually has been heard in environment, right, Chair Lee? And so it will be carried in environment, not here, but we don't actually need to physically move it there. So we're going to hear it this evening. So Chair Lee, welcome to the committee, and please go ahead and present House File 645.
Thank you, Chair, and thank you, committee members, for the opportunity to present House File 645. And for those members that have been sitting on health, I think this is the third time that I have brought the proposal forward. So members, currently money recovered by the Minnesota Pollution Control Agencies in litigation or in settlement of a permit violation that could have resulted in litigation is state money and must be deposited in the general fund. So my bill creates an exception when the Pollution Control Agency recovers $250,000 or more in litigation or enforcement settlement from a permit violation, and requires that 40% of the money recovered to be redistributed to the local community health board where the facility is located. And the MPCA must notify the applicable community health board within 30 days of a final court order and the litigation or the effective date of the settlement agreement, and collect the money and transfer it to the applicable community health board. The health board must meet with the local community impacted by the permit violation and incorporate their concerns into a project that addresses the residents' health concerns resulting from their exposure to pollution. The community health board may recover administrative costs related to the provision of this paragraph, and then the proposal directs the transfer and use of the money only and does not create a right intervention in the litigation or the settlement of the enforcement action for any person or entity. And that's the bill, Madam Chair.
All right, thank you, Chair Lee. So is there anyone else who would like to testify on the bill? All right, I'm not seeing anyone. Members, questions and discussion? Okay, I'm not seeing anyone. So, yeah, Representative Nadeau.
Good evening, Madam Chair. Sorry about that. Sorry I was a little bit late. My question is, and I'm sorry I haven't seen this bill before tonight, and so if you've mentioned this already, I apologize. But who has oversight over the spending of the dollars in this?
Chair Lee.
So, Madam Chair, Representative, so the funding will, once the money is collected from the MPCA, that will give it to the local community health board. And so, for example, if, you know, one of the incidents why I'm bringing this forward happens to be in the city of Minneapolis with Northern Metals Recycling. They entered into enforcement settlement, and portion of that funding was given to the city of Minneapolis local public health to do some of the work. Unfortunately, they weren't here to be able to testify on this, but it will be the applicable local community health board.
Okay.
Representative Nadeau?
Yeah, thank you, Madam Chair. Thank you.
Yeah. So I thank you, Chair Lee, for bringing this bill. And I think, if I recall, this was an idea that you had because you wanted the money to go when there's a settlement. I think you had the very reasonable idea that the local public health boards should help to determine how to respond, right? And that the money should go to the local areas where the pollution happened to help with remediation. Is that accurate?
That is correct, Madam Chair. So, you know, wherever, if there's going to be any violation or any settlement in the future, whether that's, you know, here in, in the Twin City metro area or in greater Minnesota, if there's a violation that fits this, then, the local community health board will receive the funding to work with the local communities that has been impacted. And just for a frame of reference for all of you, over the last 5 years, there's only been 3 cases that have fit this. One of them is Northern Meadows, like I mentioned, in my district. The second one was Water Gremlin in the Northeast Metro. And then the third one was the Southern Minnesota Beet Sugar back in 2017.
Okay. All right, and next we've got Representative Smith, then Carroll, then Keel. Representative Smith.
Thank you, Madam Chair. I'll just be quick and say thank you so much for bringing this forward. And since we are the Health Committee, I think it bears saying that many of these funds we get from litigation, I mean, this is, for lack of a better term, blood money. It's communities that have horrible health outcomes or long-term disabilities or several other horrible things simply because they lived in a particular place, normally low income and normally communities of color, that we as a state or a company allowed this pollution to take place. So at the very least, this money going back to these particular communities rather than general fund, I think is the very least we can do. And there's much more that we will do in this environmental justice issue, but I just thought that was bear saying what we're talking about here in this bill, and wanted to thank Representative Lee for bringing this forward.
All right, thank you. And Representative Carroll.
Thank you, and thank you, Chair Lee, for bringing this bill. I just had a question, and perhaps it'll demonstrate my ignorance if I have, well, I have plenty of ignorance. But I can see how this is applicable to certainly cities as big as Minneapolis or St. Paul, but is every city deemed to have a public health department? I know Minneapolis and St. Paul does, but like my community, Plymouth, we don't have a separate public health department. So in that case, do you know if there's a department or part of the city that's deemed to be, a public health department?
Chair Lee.
So, Madam Chair, I would like to ask nonpartisan staff if they could just enlighten us with regards to the community health boards.
Yeah, Ms. Clark-Fist.
Madam Chair and members, all areas of the state are covered by community health boards. So in some cases, it's a city that's the community health board, and in other cases, it might be a county, and in other cases, it's a group of counties working together. But all areas of the state have a community health board.
Okay. And Madam Chair,
Representative Carroll.
so in my instance of Plymouth, it would be probably Hennepin County then.
Madam
Ms.
Chair,
Clark-Fist.
Madam Chair and Representative Carroll, I'd have to look up your area,
Okay.
but I can do that.
That's okay. You don't.
Okay.
I just was
Okay.
curious.
All right, thank you. And I'm getting the idea that these mics might not be working so well. Can people hear us? Yes, okay, all right. But maybe we're having the same mic gremlins as we do in our normal room, it looks like. Representative Keel.
Thank you, Madam Chair. I had to do a little defending when I hear that comments like at first we talked about the third issue was sugar, Southern Minnesota Sugar Company. And while I'm not a part of that, just wanted to clarify that, I'm not a part of that company. I'm a sugar beet grower, and I happen to know that that is a rural area. And the site for the contamination was actually organic fluid that ran off of the beets. They're just like any other vegetable. It's a vegetable. It started to disintegrate as it can do in the spring, and then they discovered some problems with it. But I just wanted to point out that not everybody is trying to destroy a low poverty area that is an industry that takes care of provides a lot of jobs. And it was just an instance that happened, not intentional. So I want to remind people that there's other things going on besides intentional contamination. Thank you.
All right, thank you, Representative Keel. So final word, Chair Lee.
Thank you, Madam Chair. And I think just to that point, I really appreciate you bringing that up, Representative Keel. And, right now, currently, like I mentioned in my opening remarks, the funds that's recovered goes back to the general fund. And I think that all of us could agree that if there has been an impact to our local communities, that there should be something that will be done to benefit our local communities. And so, Madam Chair and members, I really appreciate the discussion tonight.
All right, thank you very much, Chair Lee. So with that, House File 645 is laid over. Thank you. Next on the agenda is House File 742, Representative Norris. And the chair will move House File 742 to be re-referred to the Commerce Committee. Is that correct, Representative Norris?
That is correct, Chair Liebling.
Great. And there is an A6 amendment.
Correct.
And did you want to put that on right now to put the bill in the form you want to discuss it?
If we could.
All right. So I will move the A6 amendment. All in favor of the A6, please say aye.
Aye.
All opposed? Motion prevails and the A6 is adopted. And please go ahead and explain your bill as amended.
Thank you, Chair Liebling and members. It's great to be with you in the Health Committee. So this bill, House File 742, is about protecting our heroes, Minnesota's firefighters. For years, PFAS has been used in firefighting foam. And it turns out PFAS is also in the turnout gear that firefighters wear when responding to a call. So whether it's our firefighting heroes or courageous Minnesotans like Amara Strandy, whose advocacy is leaving a lasting legacy on this issue for our state, so many people have suffered life-threatening health conditions because of PFAS, also known as forever chemicals. We don't want any Minnesotan to suffer from exposure to these chemicals, but some of those most at risk are our firefighters. With the danger of these chemicals only becoming more apparent, we must take action to address the use of PFAS in firefighting foam and turnout gear. In 2019, Minnesota prohibited the use of firefighting foam that contains PFAS in training and testing situations. This bill sets Minnesota on a course to ban the use of PFAS-containing foam in all situations by January 1st, 2024, while giving some additional time for oil refineries and airports to make the transition due to unique conditions at those facilities. It also commissions a report from the MPCA with cooperation from the Minnesota Department of Health on how we can transition away from the use of PFAS in turnout gear for our firefighters. It also establishes a voluntary firefighter biomonitoring program within the MPCA, which may partner with the Department of Health on its implementation. With the devastating health and environmental impacts of PFAS so clear, we should not permit the use of these chemicals in firefighting foam or turnout gear a day longer than absolutely necessary to protect public safety and our firefighters. And with that, Chair Liebling, I would like to turn it over to my testifier.
All right, thank you very much, Representative Norris. So we have Ivana Stark. Welcome to the committee. If you would just introduce yourself for the record and go ahead with your testimony.
Chair Liebling and members, I am Ivana Stark, State Director with Clean Water Action. Clean Water Action works to ensure that all of Minnesota has clean, fishable, swimmable, and drinkable water. PFAS is a direct threat to our water and human health. PFAS exposure has been linked to low birth rates, low IQ, reduced immune response, thyroid disease, digestive system issues, cardiovascular problems, cancer, reproductive system issues, such as testicular cancer, preeclampsia, increased infertility, and gestational diabetes. These chemicals bioaccumulate, which is why they are called forever chemicals. And once inside our body, they attack our DNA, and that damaged DNA replicates, causing the health issues I've just mentioned. In your written testimony, you'll see letters from children and parents of Tartan High School, which is in the 3M PFAS plume area, and some brave firefighters who couldn't be here today. They all tell their stories in great detail, what it has been like to live with these diseases or watched their loved ones suffer from these diseases. This is why the biomonitoring portion of this bill is so crucial, to detect potential illness sooner rather than later. Don't be bulldozed by large chemical companies from DC and around the country that are flying in and their allies who declare that they cannot do the things that they have shown they can do and have done in other states. 11 states have put in place bans on the sale of firefighting foam containing PFAS. Australia has banned it, so has Denmark. and the entire European Union is reviewing a proposal to ban PFAS in all products with very few exceptions. Our firefighters want us to pass this bill. 16 states are pursuing litigation against the manufacturers of PFAS chemicals for contaminating water supplies and other natural resources. 17 state attorney generals have called on the EPA to add PFAS to the chemical of significant concern list. Class action lawsuits against chemical companies and against product manufacturers who knowingly use PFAS are piling up, and so is the disinformation these companies are trying to spread. We have got to act now to protect the health and safety of our water, which has a direct impact on human health. I encourage your support of House File 742. Thank you.
All right, thank you for your testimony. Is there anyone else who would like to testify on the bill? Okay, I'm not seeing anyone. So, members, as you might have gleaned, the reason the bill is here is because there are some areas here where the Department of Health is being asked to work with the Pollution Control Agency and, of course, especially on the biomonitoring piece of this bill. So any questions or comments? Representative Perryman.
Thank you, Madam Chair. Once you ban thank you, and Representative Norris. I'm just looking that this will be banned, and it has a purpose now. It's and it has a bad result, obviously. But once we ban a product, and we have such inventory shortages of a lot of things, is there a replacement that the firemen and others will use instead of this product and this foam?
Representative Norris.
Chair Liebling and Representative Perryman, it's a great question and one that I've been working with the stakeholders on. In most cases, there are good substitutes available right now. I mentioned the airports and the oil refineries for some various reasons. There's not wide availability of the perfect substitutes yet, and so that's why we've given them some additional time to comply with the requirements in this bill so that we can have kind of a smooth, orderly transition and make sure we're getting rid of the use of these PFAS chemicals, but also doing it in a way that's going to maintain public safety.
Representative Perryman.
Thank you, Chair.
Okay.
And Representative.
All right, I'm not seeing any other comments. I really appreciate this bill, and often in this committee in prior years, we've heard bills about firefighters and how they really have very highly elevated risk for cancer and other really bad diseases. And of course, it's not hard to imagine why, because, they're charging in places where things are burning, sometimes really terrible things. But when we can do something to reduce the harm to them, we ought to do it. And so really appreciate you bringing this bill.
Thank you, Chair Liebling.
So any final word?
No, I just appreciate those comments, and it's an honor to be able to carry this bill and do this for our firefighters.
All right, so with that, I'm going to renew my motion that House File 742, the first engrossment as amended, be re-referred to the Commerce Committee. All in favor, please say aye.
Aye.
Opposed? The motion prevails, and you're on your way. Thank you.
Thank you.
The next bill on our agenda is House File 1175. Is Chair Youakim here? I don't see her yet. Okay, I know she is in two places this evening, so we'll just, we can go on to the next bill until she is able to get here. So the next one would be Representative Coulter, House File 2494. And he's not here either. What? Okay. Well, Representative Frederick, it sounds like you're up. Showing up is half of it. So I will move House File 1486 to bring it before the committee, and the motion is to have the bill be placed on the general register. So let's see, Representative Frederick, I don't think there is an amendment in the packet, correct? So please go ahead and present House File 1175. Oh, I'm sorry, wrong number. I got the other number in my hand. 1486.
Thank you, Madam Chair and committee members. House File 1486 is part of a package of bills that I've been working on last year and this year as well about substance use disorder treatment. The specific provisions in this bill that bring the bill before the committee is starts on section 1. Or on line 1.12, talking about former students. The goal of this piece of legislation is that once a student completes their internship as part of their degree to become like an LADC, that they've been doing the work as part of their internship, right? They finish their internship and they graduate college, and then they have to file to get their license from the state of Minnesota. It can take 1 to 3 months for them to get that license. And so the goal of this legislation says that if that student wants to continue working at that same facility where they were already doing the work, they want to continue doing that same thing under the same supervision, that they can do that for a 90-day window until they get their license as an LADC. And this would just permit that. Again, some of the language that's been added to this, that it has to be in the same place, under the same supervision, so they can't go to a different place. So really trying to address that continuity of care piece. And then there's also a line on there that says that it's a paid, it's not just a continuation of an internship either, that it is them doing the work and that they should be compensated appropriately.
Okay, thank you for that. And so you don't have any testifiers with you this evening, do you?
I have Brian Zerbis from March who's here to answer questions, should there be
Okay.
questions from the committee, Madam
All right,
Chair.
very good. Is there anyone in the audience who wants to testify on the bill? Okay, not seeing anyone. Committee, Representative Nadeau.
Thank you, Madam Chair, and thank you, Representative, for bringing this. Can you tell me, I'm not very familiar with LADC and the rates and reimbursement rates that go along with that. I am very familiar with practicing under the license or supervision of a licensed professional. Can you talk a little bit about the rates as this intern moving to, towards licensure? Is there a step down rate reimbursement if it's a public program or if it's a private, if it's being paid for through a plan? Is there a different rate that would be reimbursed through, or is that not part of how this works?
So,
Representative Frederick.
thank you, Madam Chair. I would say under this provision, we could talk about reimbursement rates. I would actually probably invite Brian if he wants to come down and talk about reimbursement rates in general. Okay. So the point of this bill specifically would be that the or the language about former students would be focused on that they would be a full licensed alcohol and drug counselor. That they would be from a wage perspective, that they would be paid as any other LADC who is fully licensed, who had received their license from within the state. That's the intention of this, that they wouldn't have a stepped down, some sort of reduced wage, is that they would be treated as if they were a full employee at that point. But this would just allow them to practice for that 90-day window while they were waiting for their license from the state of Minnesota.
Yeah, I think that the rate discussion is kind of a little bit outside the scope of this bill. So I don't know if we want to get into that entirely, but did you want to try to address the question, if you can do it briefly?
Sure. Thank you, Madam Chair. For the record, Brian Zerbis, I'm here on behalf of March, the Minnesota Association of Resources for Recovery and Chemical Health. So the rates that are paid to the program, the SUD rates, those are the same rates whether it's an intern providing the service, the term qualified staff, licensed alcohol and drug counselor, things like that. The program gets paid the same rate. On what the language is speaking to for the intern or former student getting paid during this window is their wage as an employee. So that obviously would depend on the program. But in general, most programs for an intern or a newly hired counselor would start out at the bottom of the scale, so to speak, of the wages for an alcohol and drug counselor.
Okay.
Okay, Representative Nadeau, anything further?
Yeah, thank you, Madam Chair, and thank you for clarifying that. So, just so I'm clear, when they're they don't get paid as an intern.
Madam Chair, it varies throughout the state and throughout the programs. Some programs don't pay for internships. And I should probably clarify, the internships to qualify for licensure, students need to get 880 hours, usually in 2 440-hour chunks. Some programs won't pay that entire time. Some programs maybe won't pay the first part of the internship, but they will pay the second. Other programs will pay throughout the entire thing.
Okay. And thank you, Madam Chair. And
Representative Nadeau.
I'm very supportive of this. I mean, I think this is great. I was just curious if there was step down rates. So thank you for clarifying.
Yeah, I think I think kind of the point here was that under current law, the students just have to stop and then wait for their license to come through. And the concern was that, we are in the middle of a real vast increases right now in SUD and, all of the impacts of that. And then to have these people who've completed their training just sit and wait really deprives the public of very much needed services at this time. So that's kind of the point, to fill in this gap. Representative Carroll.
Thank you, Chair. And I just wanted to back up a little bit and explore the purpose of this bill. It's due to the lag from when the student completes its program, his or her program, and then gets his or her license. Is that typical to have a lag, or is there something with regard to this particular profession that's causing this lag?
Representative Frederick.
Thank you, Madam Chair. And yes, it's trying to address that lag between graduation and then licensure. It is an impossible number to know that how many people can financially afford to wait that 3 months for that license to come in and then start working as an LADC. And so the fear then is how many people are going out and just finding any employment that they can find. And so the intention of this is to address that specific space to allow someone to get a job right away. Because we all, anyone that's gone to college knows that those debt payments don't stop, So the financial motivation for them to find whatever is immediately available. This is trying to create this as an option for them to get a job as an LADC that they went to school for right away.
True. And Chair?
Yeah.
And I certainly
Carroll.
appreciate that, but I'm trying to find out the purpose or the reason for the lag. And I'm fully supportive of this bill. And we want to keep these people continuing in their service. But I just want, so if we do this, is 90 days going to be enough? And that's the reason for asking what the purpose of the lag is. Does that make sense?
Representative Frederick.
Yeah, I think that every agency, that might be a question specifically for, the agency that's kind of issuing some of this. And every workspace is experiencing workforce shortages. Departmental agencies are no different. I know that they try as hard as they can to get these turned around as fast as possible. But I would imagine after, graduation day that all falls in similar time, they're going to be hitting with a lot at one time. And so this just kind of helps ease some of that burden as well and to support essentially the future LADCs.
Yeah, and I think it's a good point, maybe a different bill or a different exploration, because it may stretch across different licensing boards. Representative Carroll.
Can I ask one final question? So do you think 90 days is sufficient amount of time, or should it be longer, or what?
Representative Frederick.
Out of the conversations that we have engaged in with both providers and the department, we do hope that is sufficient, and we think that will be good enough.
Okay, thank you.
Yeah, thank you. Representative Quam.
Thank you, Madam Chair, and to the author, a couple of quick questions. First, how many in a year would we probably see, and then at a time, because so at any one time, there's probably so many in a year. The second question, would one of the places they might be interning at be like adult and teen challenge? I'm trying to get an idea of the different entities that they might be at. Thank you, Madam Chair.
Representative Frederick? Or Mr., and what was your name again? I'm sorry.
Madam Chair, Zerbis, Brian Zerbis.
Zervis. Thank you.
To Representative Quam's question, so we have worked directly with the Board of Behavioral Health and Therapy, and specifically Samantha Strelo as Executive Director. She's provided some data, historical data, year over year. The two types of applicants they get are for licensed alcohol and drug counselors. In the last couple of years, there have been a little more than 300 individuals have applied. There's also what's called a temporary permit. So those individuals also can practice alcohol and drug counseling. In the last couple of years, it's averaged around 140 individuals. So year over year combined, around 450 or so individuals that are seeking licensure. And then the other question about the where. So interns in general, 245G programs like Teen Challenge would be a place where an intern could get their hours in. But there are other settings like hospitals or schools or correctional facilities that interns also can operate on, gain hours. So they would be able to continue in that setting under supervision with this language.
Representative Quam?
Thank you, Madam Chair. And to the author, it might be good if this hits the floor to have sort of a sheet with an example of the different entities. So the members might recognize this or that entity that would benefit from this activity. Thank you, Madam Chair.
All right, thank you, Representative Quam. Representative Murphy?
Thank you, Madam Chair. Thank you, Representative Fredericks. I just have a question on Frederick. Yeah, Frederick. I just have a question on the former student versus, why you didn't say like upon graduation, or even if they have to take an exam, does this wait for the exam to come back as well? I know in other areas they have a licensure exam that has to be taken, and then there's a delay after that. And I can certainly understand why that would be beneficial, but I'm wondering about those two things.
Representative Frederick?
So once they complete their internship and graduate from college, then in order to have that completion, then that's the, because sorry, let me restart a little bit here. One of the concerns that I had too was like, what if somebody doesn't successfully complete their internship? Like what if something doesn't go well and they shouldn't be practicing and given some of this leeway? And that was some of the space that I explored too. And by successfully completing their internship, and then that's what allows them to finish their degree, that then was enough for them to be able to go for their licensure. And I guess I would turn it over to Brian here to answer
Mr. Zervas?
Madam Chair, to the second part of the question about the exam, part of the difference for a person pursuing a temporary permit, they do not need to pass the exam. So for some individuals, they may choose to hold off on doing the exam. People can renew that temporary permit up to 5 times, or 1 year for 5 times. People that pass the exam can then be eligible for the full licensure to be a licensed alcohol and drug counselor.
Representative Murphy?
If they don't pass the exam, you're saying that then they can re-up their 90-day again, a 90-day again, and no?
Mr. Zervas?
So for individuals that pursue the temporary permit, they would still need to be granted that by the Board of Behavioral Health and Therapy. So for former students, after they complete their internship, they're neither a licensed alcohol and drug counselor, they're not a temporary permit person. They're just within that 90-day window post-completion of their coursework and hours that they can continue practicing alcohol and drug counseling for just that 90-day window. Once 90 days hits, if they're not licensed or if they haven't gotten a temporary permit, they would have to stop.
One more
Murphy?
follow-up. With regard to when they would be paid full as a graduate, as a licensee or having the license to do it, you're saying that the income they're going to be paid now, we'd like them to be paid at that level, even though they haven't passed the exam.
Mr. Zervas?
Madam Chair, Representative, the reimbursement rate that a person would get is really dependent on the program. So in general, a fully licensed person, may be paid more than a temporary person, but that really is dependent on how that each organization structures their reimbursement.
Thank you.
Yeah. Thank you, Representative Murphy. So, all right, not seeing anyone else on the list. So I'm going to renew my motion that House File 1486, let's see, I got to get this right here. The first engrossment is recommended to be placed on the general register and on the consent calendar. So this is a first for us, members. So we've had some discussion with Representative Schumacher, and yeah, this is a first. So, and on the consent calendar. So, all in favor, please say aye.
Aye.
Any opposed? The motion prevails, and since there were no votes, we're holding out hope that you will actually be on the consent calendar. So,
Thank you, Madam Chair and committee.
all right. Thank you very much.
It seems like there hadn't been, yeah. It felt
Okay,
like
let's
there
see. Or Youakim, she's not here. She's not here. Okay, Representative Coulter. So we're going to take up House File 2494. So the chair will move that House File 2494 be placed on the general register. I think that is our motion with this one as well. And Representative Coulter, to your bill.
Well, thank you, Madam Chair, and thank you all for squeezing me in. I know this was kind of a last-minute addition to your agenda, but I greatly appreciate it. So House File 2494 is the bill brought forward. This is the policy bill from the Board of Medical Practice. Most of these changes were included in a bill that moved forward last year and were agreed on by all parties. The new changes have been agreed to by stakeholders. And while it does not make any major changes to board processes, it does meaningfully update several sections of statute related to medical practice generally, as well as specifically sections on physician assistants and acupuncture. Additionally, it does repeal 2 sections of Minnesota rules that are obsolete. And just quickly before I turn it over to Ms. Huntley with the board, I did just want to raise the issue specifically with regards to language on lines 8.7 through 8.10. There was a concern raised in the Senate when this bill was heard, and language is in the process to address that. Hopefully, we'll have an amendment on the floor, but we were not able to get it in time for committee tonight. So just wanted to, in case anybody hears anything about that, know that that is in the works. So I do, of course, want to be respectful of folks' time. So at this point, I will turn it over to Elizabeth Huntley with the Board of Medical Practice, who can walk through the bill in greater detail.
Okay. Welcome to the committee. Please state your name and go ahead with your testimony.
Wonderful. Thank you, Madam Chair. Members of the committee, Elizabeth Huntley, Executive Director for the Minnesota Board of Medical Practice. Thank you, Representative Coulter. A nice brief summary. To the point, the majority of this bill was passed through both the House and Senate last session. About 8 words were dropped in a bill introduction, and therefore it wasn't able to pass. So we're back with that and a couple of additions. Specifically, sections 1 through 4, I'll address the Medical Practice Act, amend sections to update references to osteopathic physician organizations and examinations. It removes language that positions the board to be an accrediting body for postgraduate training at the time of application for licensure. It authorizes acceptance of the COMVEX, which is the Comprehensive Osteopathic Medical Variable Purpose Examination, comparable to the SPECS, the Special Purpose Examination, which is already in statute. And one of these general skills examinations is required when an applicant has not completed a national licensing examination within the 10 years prior to application, and is also not board specialty certified. And finally, those sections clarify examination attempts for those exams. Section 5 is specific to the Physician Assistant Practice Act. Really no substantive changes, the removal of kind of 2 extra words and some formatting. Sections 6 and 7 are specific to the Acupuncture Practice Act, removing some language that positions the advisory council for that, for the acupuncturist to determine some equivalency in an intern program, and then also removes the requirement that a certain document be notarized and allows it to be of satisfactory evidence to the board. And finally, Section 8 repeals some sections of our rules specific to professional firms that became obsolete when the Professional Firms Act was passed, specifically Chapter 319B.
All right. Thank you very much. Is there anyone in the audience who wishes to testify on the bill? Okay, I'm not seeing anyone. Any questions or discussion from members? Representative Nadeau.
Thank you, Madam Chair. Especially in light of the bill we just passed, I'm curious on a line point. I've got 2 questions. First one is on starting at line point 8.17 to 8.10. Why are we striking the ability for an intern, in this case, to practice acupuncture without a license, so long as they're under the supervision of a of a licensed acupuncturist.
Ms. Huntley, do you want to take that, or
Like-
Representative Coulter? Go ahead.
Thank you, Madam Chair. To the point that that was the specific language that I had just referenced, that,
Okay.
that in, the short answer is that we will be coming forward with language to replace the language that is being stricken that I think gets at your very concern. I think Ms. Huntley can speak to that in greater detail.
Okay. And thank you, Madam Chair.
Okay, all right.
Sorry. Thank you, Madam Chair. And then, and I'm sorry.
Representative Nadeau, go ahead.
For some reason, I didn't hear that. And then my last question has to do with one of the repealers. It's the rule 5610.0200. I'm just curious as to why we're repealing that rule.
Representative Coulter?
That one I'm going to have to phone a friend and ask Ms. Huntley to address.
Okay, Ms. Huntley.
Thank you, Madam Chair, Representative. Those are being repealed because they are all now covered in Minnesota statute, the Professional Firms Act.
Okay. Thank you. Thank you, Madam Chair.
All right. All right. Not seeing anyone else looking for recognition, so with that, I will renew my motion that House File 2494 be placed on the general register. All those in favor, please say aye.
Aye.
Opposed? The motion prevails, and you're on your way to the general register. Thank
Madam
you,
Chair.
Representative
Since this deals with acupuncture, I agree, it gives me great joy to say that folks are waiting on pins and needles for this.
You can wait.
Waiting to say that. So bad.
Oh, I can't wait for the floor presentation. Okay, I saw Representative Youakim, so let's call up House File 1175. Representative Youakim, welcome. And so I will move that House File 1175 be re-referred to the Education Finance Committee. And I don't think there is any amendment on the bill. So Representative Youakim, welcome. Please go ahead and present House File 1175.
Thank you, Madam Chair, and thank you for being patient with me. We were just finishing up education finance in the basement hearing room, which I hadn't been in for a long time. Brought back memories of, now I feel like I have to do some stand-up after Representative Coulter. So good evening, Madam and Chair members. I know you've had a long day. Thank you for being here today to hear House File 1175. I know this members on this committee are very familiar with the mechanism of third-party billing. Our school districts use this to help mitigate the cost in servicing some of our kiddos with special needs. Our school districts are facing deficits, as you know. We're hoping to fix that this year. They're facing challenges with their budgets, and their special education cross-subsidy continues to grow. It's and this bill is one of the ways that we can help mitigate part of that gap. Currently, there are a variety of services that a school district can bill Medicaid for when providing for a student with disabilities, requires health-related services, and who is eligible for Minnesota healthcare programs. These services include occupational therapy, speech, language, and hearing services, as well as therapeutic services and supports. Licensed school social workers can also currently bill for evaluations and reevaluations they do for students, but not for the actual services they provide due to the outcome of these evaluations. The bill would allow for reimbursement by medical assistants of a licensed school social worker services based on a student's IEP if the services are provided by an individual who holds a master's degree in social work, is licensed by the Board of Schools of Social Work, is licensed by PELSB, Professional Educator Licensing Standards Board, it's just easier to say PELSB, as a school social worker, and currently holds an independent clinical social worker license from the Board of Social Work, or holds a graduate social worker or independent social worker license and is supervised by a licensed independent clinical or social worker. I know this committee is also very familiar with the alphabet soup, but I was trying to say the full names there.
Yeah, and please don't assume anything, because we didn't have any overviews this year, and, so please do explain it all.
All right. Our other states have allowed these types of services to be billable to Medicaid and have brought the additional federal money into their state in order to further serve students. This bill would allow Minnesota to tap into those funds that have been left on the table, funds that could go directly to support our students who have the most needs. Members, in your packets are letters of support that include a joint letter from the Coalition of Licensed Social Workers, Pacer Center, National Association of Social Workers, the Minnesota chapter, Minnesota Administrators for Special Ed, and a variety of statewide school board and school administration groups in education finance we call the cartel. And there are also a few individual letters of support. I also have two folks with me today that can further highlight the need for this legislation.
All right, thank you, Chair Youakim. So first on my list, we have Kathy Kimani. If you would come down, and then I have Rob Arnold after Ms. Kimani. So welcome to the committee. If you would just get settled and introduce yourself for the record and go ahead and give us your testimony.
All right, good evening, Chair and committee members. My name is Kathy Kimani, and I'm a member of the Minnesota School Social Workers Association, a licensed school social worker, and a licensed clinical social worker. So I've worked in schools, in St. Paul schools, actually, for over 26 years, and in my current role, I lead our district-wide school-based mental health programs, and I believe any success that I've had in that role is largely due to the fact that I understand both the education system and also from my work in community mental health, the mental health system outside of our school doors. As a licensed independent clinical social worker, I've completed the same education, clinical supervision requirements, licensing exams as any other LICSW that chooses to practice social work in a community mental health clinic. School social workers, like myself, are also held to the same continuing education requirements and practice standards that exist in Minnesota social work licensing statute. So for close to 20 years now, and you did hear that right, 20 years, I've been advocating for a shift in current thinking as to how medical necessity is determined for IEP health-related services provided by a school social worker. This shift is needed for school districts to efficiently and effectively bill Medicaid in the school setting. And like Senator Youakim said already, there are several states across the country, Virginia, Michigan, Illinois, just to name a few, that currently bill federal Medicaid for behavioral health services provided by clinically licensed social workers or school social workers under the supervision of a clinically licensed social worker. In those states, behavioral health services are deemed medically necessary through a comprehensive special education evaluation and the IEP team process. So we need to understand that the special education evaluation is a lengthy and extensive process, usually taking up to 6 weeks. It's a multidisciplinary team and considers the cognitive, academic, social, communication, sensory, emotional, and behavioral needs of a student. The special ed evaluation considers qualifications for meeting the criteria for educational disability, but also considers the necessity for related services like speech therapy, occupational therapy, nursing services, personal care assistance, and school social work services. So right now, schools are able to use this comprehensive special education evaluation and the individual education plan to bill for most of the services that I mentioned, except for school social work services. So not making any adjustments to the process to bill for mental health services on an IEP, Minnesota has left millions of federal Medicaid dollars on the table, and those funds were intended to offset the cost of special education-related services, including school social work service. Special education has historically been underfunded, and we need this funding stream to provide students the services that students are entitled to. My hope this evening is that I've conveyed two messages to you. One, that school social workers are highly qualified mental health professionals and practitioners, and we're guided by a national practice model that states we provide evidence-based education, behavior, and mental health services. And also, it's time for a change in the Minnesota Medicaid billing system in order to allow schools to access the federal, it's only the federal portion, the federal Medicaid funds for school social work service that are listed on an IEP. Thank you very much for your time and attention this evening.
All right, thank you. Thank you very much, and thank you for your work. I think we all appreciate that school social workers do a lot of good work with our kids. And this committee knows, too, that mental health crisis is very serious, and children really are suffering a lot.
They are.
Or I should say a lot of children are suffering. Rob Arnold? Welcome to the committee. Please go ahead and state your name and your affiliation. Go ahead.
Madam Chair, committee members, thank you. My name is Rob Arnold. I'm the Assistant Administrator for Medicaid Reimbursement in St. Paul Public Schools. I'm a licensed speech-language pathologist and a proud parent of 2 young adults who have both received mental health supports through the schools, and I'm here to support Bill 1175. I've been in my current role for about 1.5 years, and I've quickly learned that St. Paul Schools alone is missing out on an estimated $4 to $5 million annually in reimbursement for special education mental health services. The statewide estimate is over 20 million when you include all the students who receive mental health services through special education. The reason is that the CTSS benefit requires school social workers to complete a diagnostic formulation and give a mental health diagnosis to a child as part of their special education evaluation. However, these requirements for reimbursement are not part of special ed law and are actually discouraged by the Center for Medicaid Services. According to CMS, states can determine that some services are medically necessary for children and youth without a diagnosed behavioral health condition. The CTSS benefit has changed slightly over the years thanks to the work of many individuals and committee recommendations. Still, only 6 school districts utilize this benefit because the requirements at the heart of CTSS have not changed. Therefore, schools must use 100% of their educational funds to pay for services rather than seeking available federal dollars. As a colleague of mine remarked, CTSS is a meaningless benefit. To close, I'd like to add that modifying or eliminating the CTSS benefit will not change the services students receive in the schools. School social workers across Minnesota provide high-quality, medically necessary mental health services to students right now. This bill will begin to allow school districts to access available federal funds for reimbursement. Thank you.
All right, thank you, Mr. Arnold. Is there anyone else in the audience who would like to testify on the bill? Okay, not seeing anyone. Representative Bierman.
Thank you, Madam Chair. Thank you, Representative Youakim, for bringing this bill forward. And I wonder if Ms. Kamani or Mr. Arnold could come up and answer a question regarding the billing procedure. That's where I want to go with this. So this is really a win-win. We have all these needs in schools for kids, and we have this funding that could be available at the federal level directly to the schools for the treatment in the schools. And I'm a big advocate of school-based health centers and utilizing whatever a school, a local entity may need in their community and try to match up the needs of the kids with the available benefits. So I'm really excited about this bill. So, but my question is in regards to the funding and the payment model. And so I listened to what you said about the payment coming through the social service provider or the school itself, or if there's a clinic involved. I had understood that school-based clinics did their own billing and it was sort of separate from the education, the higher ed school budget. So I was just wondering about the definition or the delineation between the school and the healthcare services. Sounded like it was sort of, there was some cross-pollination there, and I just wanted to clarify that.
All right, Ms. Kamani.
Yes, so Madam Chair, members of the committee, so if there is, I think I mentioned that I manage the school-linked mental health programs in our school. So we have maybe 10 providers actually providing mental health service in about 50 of our schools across St. Paul, and also have some school-based clinics. Those providers for their services do bill medical assistance or any healthcare programs just as if they went to the actual clinic, although they're in our schools. That type of billing and that type of service is very valuable to schools and community and kids and families, and that will continue and not be changed by this at all. That is a medically necessary service that families or young people voluntarily access in our schools. What we're talking about here is services that are provided to a student with special education services and actually listed on their IEP. And so if...
And let me just stop you there. IEP might need to be explained.
An individual education plan. So when a student has a educational disability, the school then writes an individual education plan and lists all the services that they qualify for. So they may see a teacher for a couple hours, a special education teacher for specialized instruction, a speech therapist, and then also may see a school social worker for counseling, mental health, behavioral health support. And that's what we're talking about, those services that have been identified as needed by an educational assessment and is on their individual education plan. The school district would then bill Medicaid for those services, and then we would receive just the federal portion of the Medicaid comes directly back to the school district, and those funds have to be used for special education services to students in the district.
So one follow-up.
Okay, well, Representative Youakim.
Oh, thank you, Madam Chair. And I wanted to kind of highlight something that Ms. Kamani also said in her testimony, and that was a good question, Representative Bierman, and kind of that difference. Not all of our schools have school-linked mental health programs. I wish they did. I wish we could fund that. And that same social worker with that same license in a school-linked mental health program can bill for the work they're doing, and that same social worker could walk across the hall and walk across and go to a different school that didn't have the school-linked mental health, provide that same service, and wouldn't be able to bill.
Okay,
So-
Representative Bierman.
Thank you, Madam Chair. Then that's the good thing about you bringing this bill forward, so we can connect the work we're doing and get the people paid who are doing it and compensate the schools. The last piece of this then is if CMS is only paying a portion, how is the school reimbursed for the balance? Would it be from this bill then? No.
No, part of the, Madam Chair, members of the committee, part of the reimbursement the state part comes through the Minnesota Department of Education. So we are getting state funding for our special education service providers that way.
Thank you. Hope we can get more of this. Appreciate it.
Representative New Brindley.
Thank you. Thank you, Madam Chair. Sorry, I don't know if I can get close enough to that microphone. Can you hear me? And thank you, Representative Youakim. This bill seems like a no-brainer to me. I like it a lot. I just have a couple of questions. And just going off what Representative Bierman said and the response you just gave, the state already pays a portion of this. This would just give us access to additional federal dollars. That's correct? So there's no additional cost to the state. This is just to access the federal dollars.
Madam Chair.
Representative Youakim.
Representative Brindley, that is correct.
Excellent. Thank you, Madam Chair.
Representative Brindley.
Thank you, Madam Chair. Then my only other question, I think Mr. Arnold may have addressed this. My only question is, I was looking through this document that shows a little bit of the differences or what's the same in the two assessments. And it looks like there are just a few items that are not included in the special education documentation. And so I just was curious how that affects the process, if those are inconsequential items or are they covered in other ways? How does that work?
Ms. Kamani, you want to address that? Or Mr. Arnold? Okay.
Yeah. So, Madam Chair.
Arnold.
Thank you. It's my understanding right now that as long as the requirements of a diagnostic assessment are included in the evaluation report, that then and the school participates as a CTSS provider, that those services would be reimbursable. And Ms. Kamani can speak on this some more. The sticking point is around the mental health diagnosis and the diagnostic formulation, which by themselves are not required as part of the special ed process.
Representative New Brindley?
Thank you, Madam Chair. So then, am I understanding correctly then, the items in this chart that would say not applicable are not required? Those probably don't have to happen? And it sounds like if they are required and not currently being performed in a traditional IEP, those items now would be done just to meet the requirements? Does that make sense?
Do you want to speak to the specific requirements? Yeah.
Okay, you should have 3 chairs up there. Ms. Kamani? Go ahead, please.
Madam Chair, members of the committee, I have seen this document before, but it's been a little while since I've seen it. And is my understanding that, I'm looking at what the page you're on here, is that some of the pieces that are non-applicable, so I would say like actually having a DSM diagnosis, which is part and required in a diagnostic assessment, that is something that we're saying we would want to only use the evaluation from special education as it's listed in here and not have that be part of, not have that be required. Does that?
Representative New Brindley?
Thank you, Madam Chair, and thank you for that. And just to be clear, I assume, frankly, you are clearly the person with expertise here. I assume that based on your expertise, there won't be holes. I mean, obviously, the real goal is to make sure that kids are getting the services that they need. And I assume that based on what you're saying, these kids, even without those maybe specific pieces, the kids are going to get the services they need still.
Ms. Kamani?
Madam Chair, committee members, yes, kids are getting the service that they need based on these evaluations. And I think Mr. Arnold mentioned that whether we're able to bill for them or not, these services are being provided. And so we are able, as a clinical social worker, I'm able to bill for the assessment that I do, part of the special education evaluation, but not the services that my assessment identified as needed. And so that's where I think, doing the assessment, which does include a mental health screening, which if a parent gives us access to this, would include a review of any sort of mental health services a student had outside of school, all those types of things. It would include all those, social history, all the things that are required to determine a need for the service on the IEP.
Okay, thank you. And I do want to note that just that I am aware that there probably are some systems costs here. So I don't want anyone to leave this meeting thinking that it's just completely, free to Minnesota. Just there could be some system costs. Okay, Representative Quam.
Thank you, Madam Chair. And while I was on the Byron School Board, I was also on the ZED Governing Board. And we did special ed and gifted and talented and things across several school districts. Part of the time I was the treasurer on that board. So I'm curious as to estimated funding stream, total in the state, and then what we think percentage-wise this would affect the cross-subsidy.
Madam Chair.
Representative Youakim.
Just based on, I'm not always great at the back of the napkin math, but just based on the comments that we're leaving about, $20 million on the table? A year. So currently, if we were to fill the whole entire special education cross-subsidy, the 100%, including the federal portion, it's over $1.5 billion. If we're going up to about 60%, which is our state portion, it's 60% of that, which I can't do in my head right now. But while it's so proportionally, it's not a ton of money compared to what that cross-subsidy is currently, but it is money, and it's money to the schools for the work they're already doing. And it's a funding stream that they haven't been able to tap into just because of a different diagnostic tool being chosen by the Department of Human Services.
Representative Quam. Representative Nadeau.
Thank you, Madam Chair. And thank you, Representative Youakim, for bringing this. It's very confusing, but it's really important. And I think the point we have to remember, and I'm not as familiar with reimbursement with IEPs and drawing those dollars down as I am with CTSS. I do a lot of work with school-based mental health. And the biggest difference that I'm seeing here that I'm trying to get my head wrapped around is that what students qualify for in an IEP is very, very different than a diagnostic assessment that's been done with a mental health diagnosis. And so if you've figured out a way to draw dollars down from the federal government without that, I applaud you, and I think it's great and it's important. What I want to ask about is most of the largest significant component of kids with mental health diagnosis have it's about 65, and I'm familiar with in Hennepin, so I'm sorry I don't know about Ramsey. It's about 65-70% of the kids have private health insurance. And are you able, with IEPs and this format, able to bill commercial plans for these services?
We'll get our billing guy back up for that.
Mr. Arnold.
Madam Chair, thank you. So billing through private insurance is what you're wondering about?
Correct.
Yep. So currently, I believe there is one school district in Minnesota that is trying to do that for mental health services. Other districts are not doing it right now. It would be through the school-based community service benefit.
Representative Nadeau.
So you're missing, so by going in this model, you're missing a lot of, you're missing a lot of billing. You're not?
Oh, go ahead. We have a new phone a friend. Sorry about that, Chair.
Okay, well, please introduce yourself for the record.
Yes, I'm very sorry about that. Thank you for your time. So my name is Stephanie Schmitz, and I'm an Assistant Director of Special Education for Southern Plains Ed Co-op in Southern Minnesota. The law clearly says that what we provide for students in schools must be a free and appropriate public education. So we cannot bill private insurance because there are copays, there are deductibles, and everything else that goes along with that. So if the comprehensive assessment and the IEP determines that a student needs the service, we are legally obligated, and we want to make sure we're providing that service to students to make sure they get that free, appropriate public education.
Representative Nadeau.
Thank you, and I think that answers my question. So going about this way through the IEP process, you are prohibited from billing private insurance for mental health services.
Correct.
So there is a gap. So in order to provide those services through this population, you would need to have a CTSS mental health professional, or in order to be able to bill private insurance.
Ms. Schmitz.
Ms. Schmitz, yes. Thank you, Chair and committee. So it's really like you said, it's convoluted, okay? So in rural Minnesota especially, we don't get to access the school-linked mental health grants as often because we don't have providers who can staff them. And we have a lot of advanced practice social workers in our communities, and once a school social work position becomes available, they're coming into our buildings and serving our population because they were already serving these students. And many of our students don't have access to outside providers because in where I serve, students would have to travel 30 to 60 miles in order to find someone to see in person.
Representative Nadeau.
Okay, and thank you for that. And Representative Youakim, I am in support of this. I mean, this is I hope that it works. I hope that it works well, and I think it taps into a resource that has heretofore been untapped. So thank you for bringing it.
Madam Chair, one follow-up.
And Representative Bierman.
Thank you, Madam Chair. Ms. Schmitz, I just wanted to follow up. So you said that the rural areas where there are not enough providers, that's why we can't tap into school-linked mental health in those areas.
Yes, it's very hard to tap in. I'm sorry.
So and a social worker could not provide that service because they're not trained, so we need to just figure out a way to expand the pool, the network.
They are.
Ms. Schmitz. Yeah.
Thank you, Chair. Our social workers are trained. Right now, our only option outside of school-linked mental health is CTSS. CTSS duplicates all the paperwork pieces we are already doing. So that comprehensive assessment we talked about earlier, we are assessing every aspect of a child's needs in school, behavioral, academic, intellectual, it's all in there. And so once a need is identified, we provide the service. And the school social workers I employ are advanced practice social workers. So they're providing the services on those IEPs. We just don't bill for them because the state says we provide those services. And we want to provide those services because we want what's best for kids.
Sure. Thank you, Madam Chair. And yeah, that's enough for now. We can delve a little deeper. Thank you so much.
All right, thank you. And so, yeah, my understanding, and so if I'm, and this isn't the first time I have talked to folks to try to understand this. It is confusing. Just to clarify for me, am I understanding that even though you're talking about having individual social workers bill for their services, really the money is coming to the school? It's not like a provider, not like the school linked, where they're billing individually and the money is going to either their own practice or the practice they work for. This is the school is getting the money. So it's really bringing in an extra source of income to the school, which the school then hopefully would use to expand the availability of providers in the school, right? Is that right, Ms. Schmitz?
We are actually required to use our third-party billing dollars for those very services.
Oh, thank you. I'm very glad you made that point really clear. Representative Kwan?
Thank you, Madam Chair. One of the toughest thing that we had was the federal dollars always were very structured, and we had difficulty. So we'd use the federal dollars first, and then we would use the state dollars because there was more flexibility to try and cover. And that's why I always appreciated the state had the flexibility, because children don't always fit into, one bucket or silo. Thank you, Madam Chair.
Thank you. Thank you very much for your testimony. I'm going to invite someone from DHS to come down and just to talk about this a little bit. And just so members know, I think there is still some discussion to be had on this bill. And I think we probably will need some technical assistance. If this was easy, it would have been done already, right? And so there is a little more work to be done on this. And my intention this evening is to have us move the bill to Education Finance, which is, as you all know, Representative Youakim chairs, and it's her bill, and she will continue to work on the bill. And we're not exactly sure, it may have to have some changes. We're not sure if there's some additional funding that might be necessary and where that would be carried. So just to be really clear with everyone, this is not a kind of a done thing. So Ms. Grom, welcome to the committee.
Thank you, Madam Chair, members. My name is Christy Grom. I'm with the Department of Human Services. And thank you, Representative Youakim, for working on this important bill. We do, in general, really agree with the policy goals of this bill. We want to make sure that kids and youth in schools have access to high quality, effective mental health services. We have provided some technical assistance, as you mentioned, Chair, and so we hope to continue discussions with the bill author and with proponents of this bill. I think one of the concerns from our perspective is using the individualized education plan in place of a diagnostic assessment. So those are not equatable documents. We have provided guidance over the past maybe last year or so as we've been working with stakeholders to find ways to streamline the IEP requirements with the diagnostic assessment, as long as the diagnostic assessment is completed by a practitioner or mental health professional who's qualified to make those determinations. And so there's ways to streamline those documents and make things easier for schools, but an IEP determines educational necessity, which is defined in state and federal law, whereas a diagnostic assessment is what determines the medical necessity. So a little bit of work to be done on this bill, but overall, we really appreciate the efforts. We do want to make sure that we're getting services to kids and families as quickly as possible and in, the highest quality possible as well.
Right. Well, given the crisis in mental health in our schools, I think that this should be the year if we can possibly do it. And I appreciate your and the department's work to, find a way that we can move this forward. Because I think you're hearing in this committee, there's a lot of interest in this. And we all view it as a real opportunity, and we would like to do it. And I did hear from others that other states are doing it. So, one wonders how they made it work. Maybe there are some lessons to be learned there. I have a couple other members. I don't know if they're from Ms. Grom or not, but Representative Keel and then New Brindley.
Thank you, Madam Chair. My experience with it was as a school board member, and we did it for a while. Now, it was, we're already doing those services in the school. So what it did was defray the costs that we had. However, when we lost that ability, then it was harder to do, harder to get enough people in to work with the students. The IEP has to happen no matter what. The diagnostic happens because the family needs it if nobody else does. And it just really was effective for helping students and the families. So it's an excellent program. It worked really well to help students. And I think if there is some hiccup there, we need to figure it out because, like I said, we were doing it before. And that had to have been 15 years ago that I was on that board and we did it. So anyway, thank you.
Thank you. Representative New Brindley.
Thank you, Madam Chair. And yes, my question is for Ms. Grom. So you laid out the concerns. I'm wondering if you can tell us a little bit more about why you have those concerns. I mean, like I said, I guess that was kind of going to my question about sort of the differences between the two. And are you concerned that there will be holes in the diagnostics? I mean, it seems like these kids are receiving the services already, regardless. Is there a concern with the interaction with the feds and some kind of risk involved in that? Why is there concern with this?
Ms. Grom?
Madam Chair, Representative, I think a few of the points you touched on are all true. So we do have some concerns with the way this is written currently, not that it can't be adjusted, but to get it approved by the Centers for Medicare and Medicaid Services, and other states have done this. Other states structure their benefits a little bit differently than Minnesota, but that is one concern that we have and have provided technical assistance to address that potential risk. And we do have concerns, I think, as does the mental health provider community, advocacy community, about interchanging and using a diagnostic assessment, or not using a diagnostic assessment for the same kinds of medical behavioral health services that are provided in schools, and then having a different standard in schools than there is in the community, for example, when kids and families access these services. So we want to make sure that the appropriate professionals are providing that assessment and making those medical determinations to refer kids to the correct treatment. So it's an issue of, I think, quality and comparability for accessing services both in schools and the community, and then some of the federal approval piece as well.
Representative New Brindley?
Thank
Sorry,
you.
I can't see you from over here.
Thank you, Madam Chair. And thank you for that explanation. It sounds like, and maybe I misunderstood, but it sounds like the school social workers who are doing this are fully licensed social workers, just as they would be in a community setting. So from my perspective, it seems like that piece of it is probably okay. But I do appreciate the concern about getting that federal approval, because certainly we want to do this in a way that will expedite approval from CMS. So thank you, Madam Chair.
All right, thank you. And with that, thank you very much, Ms. Grom. Appreciate your coming down. And so with that, I will renew my motion that, I want to make sure I get the right bill here, that House File 1175 be re-referred to the Education Finance Committee. All in favor, please say aye. Aye. Opposed? The motion prevails, and the bill is on its way. Thank you very much,
Thank you,
Representative
Madam Chair.
Youakim, and thank you to the testifiers.
Every time I present this bill, I learn more, so it's very helpful, all your questions. So we'll get it done this year.
All right,
We'll work on
thank
it.
you. Okay, and now we are on to Representative Kraft. And House File 1677. So the chair will move that House File 1677 be laid over for possible inclusion. Is that the first engrossment?
Yes.
First engrossment. Be laid over for possible inclusion. And Representative Kraft, I don't think, let's see, there is an author's amendment, is there not?
There is.
Okay, so, and that is the A4?
It is, yes, the A4.
All right, so the chair will move the A4 amendment to put the bill in the shape in which the author would like it discussed. All in favor of the A4, please say aye. Aye. Opposed? The motion prevails. So to your bill as amended.
Thank you, Madam Chair, members of the committee. I'll just mention that I have Representative New Brindley to thank for the A4 amendment. She uncovered this glitch in the bill in the last committee stop. So I think we all know that the pandemic really impacted mental health, and I imagine most of us either know someone firsthand or certainly secondhand that's been impacted. Worldwide, the rates of depression and anxiety have gone up over 20%. And even prior to the pandemic, people seeking mental health treatment often faced care networks with an insufficient amount of providers and long wait times, often having to go out of network to obtain care. They'd then be paying substantially higher copayments, sometimes to the level of preventing them from getting the care they need. It's only been made worse by the pandemic. So this bill does four things. First, and in Section 1 of the bill on general insurance network adequacy, the base criteria used today is whether there is a provider within 30 miles or 30 minutes, regardless of whether that provider is accepting new patients. So this bill adds new criteria for network adequacy so we can more adequately assess a network by focusing on whether people can actually obtain an appointment. Second, in Section 2 of the bill, recognizing that we're in a mental health crisis, for the next 2 years, the bill requires health plans to accept any willing mental health provider that will accept contract terms the insurance provider already uses, so that we can make it easier for children and adults to access mental health care. Third, in Section 3 of the bill, to assist mental health providers, we're trying to have health plans use the same filing timelines and prior authorization processes consistent with Medicaid fee-for-service. I'll note that this is the one section of the bill that still has some work to be done with health providers and agencies, so there's a little bit to tie up there. And lastly, in Section 4, the bill requires MDH to study the overall network adequacy issue and come back with long-term recommendations by January of 2024. So the bill does something to immediately address the crisis and directs MDH to study the overall network adequacy issue for a longer-term solution. This is something we can do right away to make the crisis better, and I ask for your support. At this point, I'm going to turn it over to Sue Abderholden of NAMI, who brought this bill to me.
All right, thank you, Representative Kraft. Welcome to the committee.
Thank you, Madam Chair. Members, Sue Abderholden, Executive Director of NAMI Minnesota and Co-Chair of the Mental Health Legislative Network, which is a coalition of over 40 mental health-related organizations. As was said, we know that we are experiencing a mental health crisis, and people are not able to access the care that they need. And, you know, as was said, currently network adequacy for mental health is determined by a plan having providers within 30 miles or 30 minutes. If plans can't meet that criterion, they can apply for a waiver. I did a count over the weekend, and there were 653 waivers granted, and only 8% were related to mental health, meaning that the networks were adequate. But we know that that's not true, because we have children boarding in the emergency room. We have families saying they're waiting 3 months, 6 months, all the way up to 18 months to be able to see a therapist. And so we need to look at something else. 30 miles, 30 minutes doesn't tell us if providers are taking new patients. or what the wait times are. And I keep hearing from providers who are actually seeking out contracts from health plans and are denied because they're told they already have enough providers in their network. Yet these providers are talking to the in-network providers down the street and are learning that those providers actually have long wait lists. The Milliman report, which examined claims data related to mental health parity, found that behavioral health care providers were 5.2 times more likely to be out of network than other med-surg outpatient. And then over 5 years, that disparity increased 500%. My national office actually found in their study that 1 in 4 respondents did not have an in-network therapist compared to only 1 in 10 that did not have an in-network medical specialist. And again, I want to remind committee that when you go out of network, you are paying more out of pocket. And yet when people are desperate to obtain care, especially for their children, they will pay that higher amount. They will go into a debt in order to obtain care. We've mentioned what is in the bill, and I just want to say that I think it is important to do a study of the network adequacy and really look at some different criteria that will actually measure whether someone can access care. We've seen other states do a wide variety of things, including looking at how many diverse providers are in their network to make sure that people can access therapists that speak another language. I also think that it's important to reduce the burden on our providers who have to deal with different timelines for submitting and resolving billing issues. I have several pages long of the complaints from providers where they might submit a bill and then it comes back because maybe the person had some other insurance or something's wrong, and it can take months. But if the health plan has a 3-month deadline, then they don't get paid, and that frankly isn't fair. I'll just end because I know it's getting late and you're all hungry. But I think we really have to look at how can we increase access to mental health care. We know that there is an issue. We know this. And so we need to look at how can we look long-term to make sure we're really measuring those networks, but also short-term to make sure that any willing provider for the next 2 years will take those contracts so we can really open up those networks. And I'd be happy to answer any questions.
All right, thank you, Ms. Abderholden. So before we go to members, is there anyone else in the audience who wishes to testify on the bill? Okay, not seeing anyone. Member questions, Representative Fisher.
Thank you, Madam Chair, and thank you, Representative Kraft, for bringing the bill forward. The question I have is for Ms. Abderholden. I very much understand the need and what's happening out there. The nonprofit I work for has gotten the same letter saying we've got more than enough providers, and I know everyone's got waiting lists out there. It's a serious issue that we've got to get on. You mentioned that there was a list of people that have been having denials and that kind of thing. Do you have that broken down? How much of it is from commercial plans? How much of it is from managed care organizations? How much might be from the state? In other words, what are the details you have, and how easy is it for us to get that information? I think that's very important for us to know what the spectrum of what issues are that we're facing, whether it's in the regular commercial side or if it's on the managed care and Medicaid side.
Ms. Abderholden.
Madam Chair, Representative Fisher, I can get you that information. When I put the list together for the Representative Kraft, I took out the names of the insurance plans in there, which I can easily put back in, but also be able to tell you whether it's Medicaid managed care. Medicaid managed care is the biggest issue that we saw in all of this.
Okay, thank you. Representative Fisher?
Thank you, Madam Chair. And this gets kind of the heart of when I introduced 983. This is the problem I'm getting at. Is a lot of the problem is the managed care organizations not providing the payment for the services that they're supposed to. And I hate to have to come back and hit on it, but the insurance plans keep on coming out, and to the insurance plans that are out there, this is one of the examples that I was highlighting before, and I expect it to get resolved, and I'm upset with what's going on.
Okay, thank you, Representative Fisher. Representative Nadeau.
Thank you, Madam Chair. And I'm going to start in section 3. I've got a couple of questions in each section, and thanks for bringing the bill. And I'm going to probably pick up off of what Representative Fisher was talking about, but I'm going to maybe take a different tack. I hope I don't irritate anyone. These are post-service authorization services. These are services that are provided by a provider. They do a diagnostic assessment. They provide those. They develop a treatment plan. they're paid for said treatment plan, they start providing those services, they evaluate those things. These are professionals. These are professional companies, and they work for other professionals. The company that I work for actually has a 90-day billing period. If you invoice post 90 days, you're automatically denied. And there's a responsibility that we all have to play a part in this. And so as I look at sections, starting at 5.30 to 5.33, going to fee for service, the state allows up to a year. That I think that's going to be an issue because, a year is a long time to be able to provide those services and wait 12 months to bill for those services. I don't know how hard it is for the state to budget. I know how hard it is for the county to budget. And we're working on budgets, long before that year is up. And we have allocations, and we just don't automatically move those dollars from year to year. So if we get an invoice for $10,000 or $100,000 from 2022, we don't have the appropriations in 2023 to pay those dollars. So can we address that? And then I'm going to move on to, I just have one more question, Madam Chair.
Okay, Ms. Abderholden.
Thank you, Madam Chair, Representative Nadeau. Most of the providers that we've talked to in the mental health community, they're submitting those bills right away. They have an incentive, right, because they need that money in order to meet payroll and all of those things. The problem is the processing of those bills, because there can be errors, and when you're dealing with people who are in Medicaid, perhaps the number changed, perhaps they actually had also have regular insurance, and then that has to be billed first and all of that kind of stuff. They've had lots of problems with some of the health plans putting in the wrong codes into their system. So it's not that they're all willing to put those bills in right away. It's the processing of the claims, and once it gets beyond that 90 days, then they don't get paid. And this is the area that we're going to continue to work on with the department and the plans, so that we're continuing to work on it. But I just want to make it clear, the providers have no problem billing right away. It's the processing of the claims that's the issue.
Representative Nadeau, you had a follow-up?
Yes, thank you. Thank you, Madam Chair, and I appreciate that. Is there anything I can do to help with that section? I'm happy to do anything I can. And then I just wanted to go to section 1. And I heard in testimony from that we're going to kind of change this. We're going to change this access, and I did hear that that there's providers out there that have capacity to see more clients, either through the plans or others. In my experience with the minimal amount of work that I do with school-based mental health providers, they have massive waiting lists. And they have massive waiting lists because their caseloads are enormous. Because there's not enough people coming into the system. They're doing everything in their power to attract master's level providers that do provide same said services. And I'm not sure, again, I don't know the difference in how this new definition in section 1 is going to affect that. And if there's not enough people to provide services, and I hope there's no penalty that's associated with this, I'm not sure if there is or not, but if there's not enough direct service providers, how can we change this and try to hold them more accountable? Are we setting ourselves up for problems by doing this? I guess that's my question. Knowing the staffing shortage that we're in with these folks.
Representative Kraft?
I think I'm going to ask Ms. Abderholden to take that one.
Thank you, Madam Chair. Representative Nadeau. We do know, though, that there are providers who are willing to have a contract with a health plan, and they're being denied. They're saying our networks are good enough. And so that's why we want to be able to say to a health plan, you can't just look at 30 miles, 30 minutes. You need to look at what are the wait times, who's taking new patients. Because especially in some of the communities, I know even up in Duluth, I've been contacted by providers who are trying to get into networks, and they're told, no, it's okay. But then we also have waivers of network adequacy for mental health in that same county. And so we do have people who are willing to do the work. They can't get the contracts. Do we have a workforce shortage? Absolutely. And that's why we need to make sure that the current providers we have in the state can be in networks, right, so that people can access that care. And I do know families are going out of network to be able to get care for their kids, and I don't think that's right.
Right, thank you. And, there's another piece of this too, and that is that at least under, managed care, under the Medicaid system, we are paying capitated rates to managed care organizations to cover care. And if they're not actually arranging to provide that care, that does seem kind of not what we're paying for. So there is a piece there as well. So Representative Nadeau?
No, thank you. I'm finished. Thank you, Madam.
All right, thank you. And I just would like to thank Representative Kraft and Ms. Abderholden for this bill. I had worked on network adequacy some years ago. And of course, members, this lives in the Department of Health, which is, puts it right in our committee. And one thing I wasn't able at that time to get beyond the 30-mile, 30-minute issue, but I completely support that because it isn't enough. We know, I hear from constituents, they go and they just can't get an appointment. They've got insurance, what they don't have is health care. And we need to make sure people get health care, especially when we are paying for it. But one suggestion I have, I don't know if it's how practical it is, but I remember at that time I suggested that the department hire a secret shopper, somebody to call up and say, can I get a dental appointment? Can I get a mental health appointment, to check. I don't know if that's really a practical suggestion, but we do hear from constituents that they're told that they're covered, and in fact, they're not really covered because they can't get the care they need. Representative Carroll, did you have a question, comment?
No, I don't.
Okay. All right. Representative New Brindley?
Thank you, Madam Chair, and thank you, Representative Kraft. I think you know that I actually do like this bill. I do think, though, that this question that Representative Nadeau brought up is worth understanding, and actually, frankly, to Representative Fisher's comments as well. It would be worth digging in and understanding where that problem is in billing. Certainly, I am confident that insurers make mistakes and that they also delay payment occasionally. But, I've got a good friend who does billing for a dental office, and it's her job very specifically to go through all of their denied claims and figure out why they're being denied. And I mean, she gives me a very specific, she just tells me, like, it's almost always their fault as the provider, that they're not providing all of the information that they're supposed to provide. They get the codes wrong. So it would be interesting and good to know, where is the breakdown in that? It's probably not fair to assume it's one or the other. It's probably some of both, but it would be good to understand the breakdown there. So that we could have a better handle on that and make sure that we're putting forward good solutions and the right solution moving forward. Thank you.
All right, and I don't want to forget that there is an amendment in the packet. Did someone want to offer this amendment, the A5?
Madam Chair, that was going to be mine, but I had overlooked something, and the author of the bill clarified that for me, and it is not necessary. So
All right.
Thank you very much.
Well, thank you, Representative Nadeau, for that. Okay, so with that, this House File 1677, the first engrossment as amended, is laid over for possible inclusion. So thank you very much, Representative Kraft.
Thank you.
And Ms. Abderholden. And members, I think we have reached the end of our agenda, unless you all want to stay here and talk some more. We can do it. Anybody in for that? No, I don't think so. Okay, so with that, we will see you all tomorrow at our regular time, and we are adjourned.